Okay, right. Hello, everyone. Welcome. My name is Richard Smuda, Chairman of the Trust, and you're very welcome to our 2020 Annual General Meeting. I think if this isn't the first, it's certainly one of the first for the virtual AGMs in the NHS. So thanks to the team who worked so hard to put this together. I'm going to take you through how we're going to run the order of events. So in terms of how the meeting's going to work, let me just take you through that. First of all, on the slide that you can see now, and I'll say I really want to pay tribute to board colleagues, and you can see here, first of all, the non-executive team here. You've got here a wide range of experience, ranging from pharmaceuticals, from local government, from clinical care, mental health, cyber, IT. We've got in the care sector, we've got a wide range of non-executive colleagues, and can I just at the start thank them for the work they've done on the board on behalf of the trust. So as you can see there, they're all online by WebEx. So if and in the room here, on the next slide, we have our exec team who are behind me, who are obviously in the room. We've then got staff partners and public able to see via WebEx, and here are our proceedings. So hopefully all the technology is working. At the outset, I'm just passing on apologies from our Chief Executive, Toby Lewis, who is away ill at the moment, and we wish him well for his recovery. We have here today, who will be presenting to you later, David Carruthers, who's our Medical Director and is acting Chief Exec in Toby's stead. If we can then just to take you through the agenda. After I said a few opening remarks, David's going to take you through the 1920 year and pick out what we've delivered against our vision. There'll then be an opportunity to ask questions of David and to members of the board. We'll have a question session then. We've got some questions submitted in advance, but obviously we've got an ability for questions to be asked electronically, which will pick up those together. So I hope you've all got an opportunity to fill the box if you haven't already pre-submitted questions. Then after those questions, we will then, I'm delighted to say we have here two of our GP colleagues, James Gwilt and Simon Mitchell from Your Health Partnership, and they're going to give a separate presentation on the work being done in primary care, and particularly around the integrating of that care and the way the services have adapted to COVID. So that'll be a second presentation after David's. So hopefully that's all clear. I just want to say a few words around opening remarks just about how the year has gone. It's been, as you might imagine, a very extraordinary year for the Trust, not just as a result of the pandemic, which clearly impacted on the last part of the year, but nevertheless, we have continued with our ambition to be a truly integrated care system. We've made a major milestone in the autumn last year when we delivered our Unity patient information IT project, was actually a critical building block to moving into our new hospital and to improving both the safety in care and the kind of information we've got to support all the services we deliver and the optimizing of those services. So that's been successfully implemented, and we're starting to get the benefits out of that. And we've made significant continued progress both on quality and safety, and obviously our ambitions working with partners on public health, and in particular our ambitions for research, which I'm sure David will touch on later in terms of not just general research, but how we've been applying that in terms of the pandemic as well. Clearly, it's been very extraordinary how in the last part of the year the pandemic has impacted on our services, and despite all the challenges of that, there have been some remarkable innovations that people have adapted to in terms of different ways of working, deal with the realities of socially distanced working and just different ways of working. So there are positives, which I'm sure we'll touch on later. I want to particularly pay tribute to our staff, who've really shown a remarkable, quite remarkable willingness and professionalism to tackle the response to the pandemic with all the support partners. And that isn't simply the frontline staff that we see so much about, but everyone's role has been adapted in some way, and it's been some of the team working and collaborative working that's been really the most impressive. And that includes not just within the trust, but also within our communities. We are incredibly proud as a board in terms of the way our staff have responded. We just couldn't be more proud, and we've shown time and again how they've gone the extra mile on behalf of patients, but also in terms of having to work in a different way in very special circumstances. I would like to pay tribute also to our exec colleagues who are behind me, particularly the leadership Toby's shown in terms of the response to the pandemic, and the executives as a team. They have responded incredibly well, and that goes through all the teams that sit underneath the executive board, all the other teams, not just the clinical leadership and nursing leadership, but also some of the key operational and some of the services that may not be directly in front of patients, but nevertheless, services are completely interdependent, whether it's the state's team or not supplied or any of these. I really want to pay tribute, not just to the leadership the executive team has shown, but also the leadership at all levels through the trust, where there's had to be significant adaptation and ingenuity as to how we've been able to respond. Tragically, of course, there have been many deaths, and this is an area where there has been a significant number of deaths on the wider West Midlands. And there have been some exceptional stories of the way our staff have supported people when their families couldn't be with them. And I know that's been very testing for our staff, and as you will no doubt hear later, how much we're trying to do for their well-being. But really extraordinary stories of the caring that's been done in quite exceptional circumstances that I know you. Whilst it's very sad, we are nevertheless very proud of what our staff have been able to do for people who've lost loved ones, and working with the families that have been very often remote from. Clearly, we've also had a significant number of people who've recovered, and we wish them well, having left our care, and we've got a wide range of stories of how grateful they are for the care they've received, and we wish them well, and obviously send condolences to those that we've lost through the pandemic. I'm just very proud in particular of the way that I think the Trust has particularly led in a number of areas with our partners, whether it be supplying PPE to neighbouring trusts and care homes, whether it's the way we've been testing not just for our staff and our patients, but also for partner organisations. We've tried to be in the vanguard of working within the system to go the extra mile to support that, and I'm very proud of the way our trust stepped up in a whole range of areas. Clearly, we've had an extraordinary response from our communities and voluntary groups is to helping in these exceptional circumstances. Incredible offers of fundraising, donating goods, of just whether it be helping with supplies of PPE. There's a whole range of wonderful stories of just support, not always asked for, just delivered. We've been overwhelmed by their support, and we are hugely grateful to the way that our community has supported the Trust and all its staff. We really are. Clearly, we are very conscious of the economic impact that the pandemic will be having in our community, and we are determined we're determined to play our part in how we can support, whether it be local procurement, whether it be making sure we're paying our bills to local suppliers on time, doing all the things we can, including working with partners on employment prospects in these very difficult times. We're determined to support those that have supported us. Clearly, I've spent a lot of time in these few opening remarks talking about the pandemic, but as David's presentation will show, the year was about a lot of other things as well. And obviously the purpose of this part of the AGM is to very much reflect on the many milestones we've reached during the year. And so I'm really grateful to you for joining us in the annual general meeting. And I look forward to the questions. And I'm now going to hand over to David, our acting CEO and our medical director.
Thank you, Richard. Good evening, everybody. Hi, I'm David. I'm Medical Director and Acting CEO in Toby's absence. I wish him all well and hope he's back soon with us. So it's my pleasure to provide the overview of the 2019-20 year and with a focus on the 2020 visions you see here from the graphic in front of you. It's built on the firm basis, the financial position of firm financial, people, estates and digital plans. And I'm going to reflect on the 5 pillar plans, showing highlights of the year as we go on. So our 2020 vision is shown on the next slide, and as is well known to you, it's to be the best integrated care provider in the NHS. And this is built on strong community teamwork with increasing links with partners in primary care and other community services. And we welcome primary care services into our trust this year, and we'll be hearing from them later as part of our discussion. So we'll be looking forward to that. Thank you. So the 5 pillar plans are illustrated here, and there's so much to reflect on. It's difficult to know really what to pick out from this, but the quality plan I'll discuss first of all, which is built on 10 clinical areas which are aiming to help improve care to our local communities. Topics will be well known to many of you from our quality account and from previous discussions of this, but the initial focus has been on improving mortality within the trust with a review of care provided to patients with infective conditions, but also cardio and cerebrovascular disease, which has seen good improvements there. Good improvements has also occurred in management of patients presenting with fractured neck or femur. We've seen an improvement in mortality, but there's still more to be done, building on the output of our pneumonia task force and sepsis screening work. So this year we started on the plans for the other topic areas in the quality plan, which will be picked up again shortly, having been suspended because of the COVID pandemic. So our areas of initial work will be around improving end-of-life care, and that's building on a strong team already. I'm pleased to say we've got 2 new consultant appointments we'll be starting later on this summer. I think the end-of-life care that was shown during the COVID pandemic really epitomizes the strength of that team and how well they worked across the organisation to help support patients and relatives during that difficult time. So we'll progress with work to reduce readmissions to hospital, develop our neonatal services, support ophthalmology in helping preserve vision, improve our screening uptake in cancer outcomes, and have a real focus on transitional care from paediatric to adult services, something that's a really important time of life for young people. We need to reduce the time that children spend away from school for health reasons and attending for appointments. And again, the use of video technology for consultations precipitated by COVID pandemic may well lead to some real advances in that project very quickly. We'll work with the orthopaedic team on their patient-related reported outcomes and improve mental health care. These are other important project areas within the quality plan. Our public health plan is reflected by the hard work of the alcohol team that we see in the picture in the middle, but we've heard about today in the Public Trust Board and their aspiration for service expansion. So some fantastic work that's been done there, supporting local community, local people with alcohol-related problems. It really is a national exemplar, and we're very proud of that. Other public health projects are around clean air and improving well-being through exercise and diet, both being maintained as important aspects of the public health plan. In advance of the quality plan, the safety plan was the real focus to make sure that all required patient safety checks were undertaken at the point of admission. The appointment of our falls champion and supported safety work on falls reduction with some good initial work being done through Rowley Hospital presently. The research and development portfolio is an important aspect of trust work, and very proud that we reached national targets this year for patient recruitment, with over 2,600 patients being recruited to our studies. Not only that, but we've also been involved with studies that have influenced national guidance, particularly in cardiovascular disease, shown here in the bottom left, reflecting the COMPASS study. We're not only just contributing to studies, but we're developing our own cohort of young research consultants who are involved in study recruitment, as well as developing their own research agenda, and that's something we really need to focus on over the coming years. And finally, the education team is strengthened by integration of aspects of nursing and medical training, particularly around simulation. And we've got the great simulation facilities, both at City Hospital and within the education here at Sandwell. This is going to be a really important component of our work over the coming years, with increased student number coming, and we really welcome students from Aston Medical School will be starting in September. And we're very pleased to be part of this exciting and important development to help increase the number of qualified doctors, particularly in the Birmingham area. I hope that we'll give them a good experience, and that their chosen place of work will be within Sandwell West Birmingham Hospital Trust, which will then be at the Midland Metropolitan University Hospital. With the 2020 vision, there have been changes in patient care, which has led to more diagnostics being open during the evenings and weekends, particularly for radiology and endoscopy. Improved convenience and access for patients with outpatient appointments undertaken nearer to home, care at home, and more continuity of care are changes that have fitted in with our 2020 vision as shown on this slide. So what next? So we've been told by patients that we excel in some areas, but there are some aspects of integrated care working well and others not so. So we need to continue our work in that area. We continue to seek patients' views to understand how we can improve, and this is done through friends and family, through Purple Point phones and surveys on aspects of clinical care. Now is the time to look forward to our 2025 ambitions, and we'll start with patient and partner engagement to define those over the coming weeks and months. I'm just going to look at a few achievements of this year, which are shown on the slide, and particularly starting with our healthcare professionals, overseas professionals project, which has been really an innovative project to help support refugees into obtaining UK professional registration to work in our local health service based on their prior experience and qualifications. And we'll be having colleagues starting the organisation soon who have been through that process through clinical attachments. As many will know, we became a smoke-free site last year, and this is the first anniversary of that date is on Sunday, which, as you'll know, is the NHS's 72nd birthday. So we wanted to support staff and local communities to improve their health, and maybe controversially, we supported the use of vaping as one way to help people get off cigarettes and withdraw from nicotine altogether. And that was just one of many approaches to helping people quit smoking, and we're reviewing the outcome of this campaign in Neuron shortly. I've already touched on our aim to improve sepsis management, building on our high rate of sepsis screening, which is between 90 and 95% of all patients who require assessment. But we now need to address any hurdles in delivering all components of Sepsis 6 and management of sepsis within an hour. So there's still some work to be done there. Falls reduction and e-prescribing have been part of the safety plan, with the latter being a major component, as we heard from Richard, around the electronic patient record Unity, which we introduced in September last year. This was a massive transformational project that affected every area and individual in the trust. The whole process really epitomised great team working to be able to get the system safely installed, building on underlying strengthening of our IT infrastructure over the previous month. Many colleagues have said, and I reflected as well, that both these IT projects have certainly been massive components of how we've been able to deal with the COVID pandemic over the last 3 months. Remote working and video conferencing are two examples of this. So great thanks to the teams and all staff involved in getting Unity set up, installed, and working across the organisation. So then there was the celebration of the work restarting for building the new hospital and the renaming of the hospital to the Midland Metropolitan University Hospital. This really was a validation of our educational and research aspirations with partner academic organisation, and we welcomed Balfour Beatty as the building contractor to complete the work. However, working with the local community to develop services in the local environment are really important factors of what happens outside as well as inside the new hospital building. I'd just like to highlight the investment as well that's gone into the neonatal unit buildings, improving parent and family experience in what can be a very difficult time. And our newly opened children's emergency short-stay paediatric unit was responding to clinical need and recommendations from the CQC, both to improve patient and staff experience. And this is something that was really achieved over a very short period of time, with very positive reports from staff and patients about how it's functioning in the 24-hour unit now at City. Our financial performance is shown just in summary here, and I really won't be able to do this, all the work that's done to achieve this justice, but just to be able to say that we finished the year with a strong financial position, maintaining with a surplus, and I understand that's for 11 out of the last 12 years. Capital projects have been invested in carefully to stay under budget, and there's a control of cash income over expenditure and an improved position on last year, with a focus on making sure that local suppliers are paid in a timely fashion, all monitored through the audit committee. So that is an important area to promote and support the local community and businesses. So I couldn't not include some discussion of the response to COVID-19 pandemic, and Richard's already discussed that, and the amazing work done by so many people and within the local community. And no part of the organisation or community was untouched by this, with a monumental effort by staff from all departments to respond rapidly in a coordinated fashion to the needs of our community. I really do wish to applaud and thank the staff for the massive change that they had to undertake to continue delivering safe care at a time of huge anxiety for many people. We see here some numbers, and you can see that there were 1,329 patients with COVID confirmed during the pandemic at the Trust. 70% of those were safely discharged, and we hope that those with health consequences because of this recover quickly. Unfortunately, the number of deaths shows that the mortality is approaching 30% of COVID patients, very similar to elsewhere in the country. But our own careful data analysis has been done, which reflects the effect of increasing age, gender, and associated comorbidities on increasing risk of death. Learning from our case reviews has been very important, and the support of our medical examiners has been key to be able to put change in place, as has noticing and responding to best practice from national documents allowing improvement in areas such as respiratory support and enhanced management of thrombosis risk in patients admitted to intensive care unit. We contributed to COVID-19 research, turning off all our pre-existing research projects to focus on recruitment to national projects, and we were able to recruit 150 patients to significant research projects that led to real early meaningful outcomes, such as showing that hydroxychloroquine was not helpful in severe disease, that antiviral agents can reduce hospital stay, and importantly, dexamethasone can cut mortality in those even oxygen going to ITU. All these changes were rapidly introduced to common practice when made available, when the data was made available. We're now down to just over 30 patients in the hospital who have tested positive with COVID-19 now, and that was down from over 200 this afternoon. We continue to focus on infection prevention and control in the hospital, and must thank all those from the local communities who supported us with gifts, PPE supplies, and their thoughts and prayers. We really are proud to be part of and serve this local community. So where to now? The focus is very much on restoration and recovery of services, but really things will not go back fully to how they were before, and we must be able to be responsive to future surges in COVID cases in both the short and long term. So planning is around both the restoration of services and having a response program in place for the occurrence of COVID cases. Really important, we work with local communities in Public Health England to be able to predict when there are local increases in infections, and also from our own hospital data, which we look at closely. We maintain our work on quality and safety. We will look at our approaches to improving patient outcomes further, especially through the quality plan. We're going to set our 2025 ambitions with our patients and continue to look at colleague well-being, building on systems that have been put in place to address the stresses of the last 100 days. I want to commend our staff for their teamwork and wish you all well and to stay safe. Thank you. That was just a brief overview of some important components and areas that we've been working on during the last year. They're all reflected within the annual report. We're happy to take any questions.
No, I was just going to say, yeah, David, thank you very much. We're now going to move to our question and answers. We've had questions sent to us in advance, and we'll deal with those. And obviously, we'll pick up any if they come in the dialogue box here. So I'm going to sit down, and Ruth, our comms director, is going to help us direct the questions that we've had pre-noted. All right, I'll sit down.
Thank you very much, Chairman, and thank you, Dave, for the review of the year. So great to see so many things that the Trust has done in partnership with others throughout the year to achieve on both our year's priorities and the 2020 vision, which is obviously our 5-year strategy that ends this year. So thank you to everyone who sent in some questions in advance. I've got those now that we'll be reading out, and I'll encourage colleagues in the room to come up as I ask them to answer them. So do bear with us. Due to social distancing, we'll be slightly further apart than normally we'd want to be, but colleagues will come in and join me to answer those questions. If you want to post a question, you haven't submitted one in advance, then you can do that using the Q&A function in WebEx. So they'll come up for us in the room, and we'll be able to go through as many of those as we can in the time that we've got this evening. We do have a torrential downpour just started in Sandwell, so apologies if you can't hear us due to the rain, but we'll do our best to speak up so that you can hear our answers in full. So I'm going to kick off with 2 questions that were submitted that relate to COVID-19. So unfortunately, David Carruthers, Medical Director, doesn't get to sit down for very long because I'm going to ask him to come up just to answer these. So 2 questions, I'll read them out and then invite David to come up and answer them. So the first question, how much accountability is the Trust taking for the devastating impact that coronavirus has had in the community, and what lessons have we learned from this crisis? And the second question is regards to BME staff risk assessments and the redeployment concerns of some staff back in April. Can we have updated reassurance that concerns are being taken seriously? Has the Trust been slow in responding to NHS England guidelines compared to other hospitals? So I'll invite David, if I may, to come up and answer those questions.
Just make sure I stay on screen. Thank you. Thank you for that. So the first question was around the effect on the local community. And I think really what we did appreciate here was that there was a very rapid change in hospital services that was required. There was massive innovation from the teams to be able to adapt to the challenges of continual changing demands on the service that we're providing. And it was that continually changing picture that was compounded by uncertainty over PPE provision and the timing of national advice and the response that we had to make to that. So we work closely with community services, providing PPE to care homes when patients were discharged, and we had early access to swabbing provided through community services. And we certainly recognise the effect on the local community, both from loss of loved ones and changes in local businesses that occurred because of COVID-19. And there were so many facets and so many changes that had to take place within the hospital that impacted out into the community. I think the lessons are around strong and clear leadership, which was really important. And we clearly had that from Toby. And I'd like to just commend him for that role that he played. Regular communication to all staff groups is important, as is the importance of wellbeing and support for staff members. And we must have plans for restoration of services, as I said a minute ago, as well as preparation for a second surge. I think learning from what we undertook over the previous 100 days to be able to respond in a more planned fashion is going to be really important for a second surge.
Okay, BME staff risk assessments, can you comment on that?
Yeah, so right from the very start, we had a risk assessment for all staff groups, particularly those with known health conditions that put them at increased risk. This was all done in parallel with a lot of work we are doing around shielding, both identifying our own patient cohort, which should be shielded, and going through lists of hundreds and hundreds of patients to identify those who need to shield, and that also would have included staff members as well. So there was a big focus at the beginning on protecting both patients and staff with the shielding, and those who were able to undertake a health assessment through occupational health because of those known comorbidities. As then more data started to come out around the BME risk, we had a symposium in May to understand the concerns of BME colleagues that was run by Toby, and it was really pleasing to see that people who generally had a positive attitude to what the trust had already done, particularly around the provision of PPE for them. It was then in June we produced a modified risk assessment for occupational health, which was based on data from published studies, and this could be undertaken by any concerned staff via occupational health. From that, advice was given to local managers on risk assessment changes that should be considered. This has now been opened up to all staff to be able to do self-assessment and then submit through to occupational health, just to make sure that we're not missing out on any staff members who are unaware of the availability and advice to undertake the risk assessment if they felt concerned about their health with COVID. So I think there's been so much rapid change going on. We've worked really hard to keep up to date with advice and guidance, producing where necessary our own risk assessments and undertaking our own work, but at no time I hope have we been behind or not recognised the risk and concern of colleagues, particularly from the BME group, over this difficult period.
And while I've got you, another question related to COVID. So a question from a member of the public who sent one in. Can testing of COVID be done on a regular basis, such as weekly?
Yeah, interesting. So I think there are probably two aspects to that question, and just to be clear, two sorts of testing going on at the moment. One is around antibody testing to identify those people who have been exposed or had COVID infection, and the other is swabbing to identify those patients who have active infection currently. So both those are available now and undertaken within the organisation. Patients who are admitted to hospital with non-COVID illness do get regular swabbing at less than weekly intervals to make sure that they don't have COVID when they came into hospital, because clinically it can be difficult to predict, and also for us to be able to predict if we've, or recognise early if we've got any outbreaks of COVID within the hospital. Staff members will also be swabbed under those circumstances. So there is an increasing availability and increasing focus on swabbing patients and staff members as a way of trying to reduce outbreaks and recognise COVID disease, symptomatic disease as soon as possible. And this obviously ties in with the other aspects in the hospital of patients and staff and visitors wearing masks within all clinical areas now to try and reduce the risk of transmission, and screening of all patients when they're coming into clinical areas for symptoms that suggest they might have COVID infection. So I hope that whole combination of factors leads to a safer organisation now that the availability is there of antibody testing and of swabbing and regular swabbing.
Thank you for that. So I'm going to ask Rafaela Goodley, Director of People and OD, to join me. I've got a few questions that have been sent in advance relating to staffing and workforce issues. I think I've got 3 for you at the moment, my fella. So we'll start with NHS job losses, which is the title from this individual who sent this in. Will this happen? Question mark. It's very worrying that a lot of people are losing their jobs in the private sector. Can you provide us with a comment on that?
Yes, of course. I think there's no one really, either within the NHS or a bit more widely, that hasn't been affected by the economic impact of COVID-19. And our staff members have been sharing stories about their family members or people that they know that have experienced job losses. During the pandemic, whilst we've been staffing our hospitals and staffing our response to it, we've actually taken on additional staff. We recruited an additional 600 people through our trust bank in order to allow us to respond to the pandemic. So we've increased our capacity at the moment. So we wouldn't have job losses as a result of the pandemic, but what we will be looking at, before the pandemic hit, obviously, because you heard earlier that we're a financially balanced trust, in order to do that, there's a series of workforce changes that we were going to do anyway over the course of this year. So now that COVID has calmed down a little bit, as you heard earlier, we're going to be re-looking at those workforce schemes. So there might be some skill mix and moving people around, but our trust always remains committed to redeployment. As a trust, we've also been working within our STP to look at the economic impact of COVID and how we can help. We're really, really grateful to our community. We want to be able to give something back to them. The STP are looking at working with the Black Country Chamber of Commerce, and Paul Moback is leading a working group with them to look at how we can support our local businesses to make sure that the economic downturn that we're going to see as a result of the pandemic, that we can do something for our community, for our patients and for the family and friends of people who work in the NHS.
Thank you for that. So I've got another question that I think is probably a member of staff, a colleague of ours. So what happens if you get really ill and cannot attend work for a long period of time?
So unfortunately, we have had quite a few staff members who have been very ill from COVID or COVID-related absence. To start with, we fully pay all of our colleagues who are shielding. So we've had a number of colleagues who've not been able to come into work the past 12 weeks. They received 100% of their pay and with the enhancements that they would have got if they'd been able to come on site. The majority of people who are shielding are working from home. So we will encourage people to do that as well, to continue to do that as shielding starts to lift on the 1st of August. We've had a number of colleagues who have been very poorly with COVID themselves, and we are supporting them on a one-to-one basis in terms of their rehabilitation, working really closely with their clinicians, with their family members and with their line managers to make sure that we're rehabbing people back into work in a really safe way. So in terms of being paid, we have our NHS terms and conditions, and we've been very much guided by our terms and conditions, but also about doing the right thing. I can think of a number of colleagues that we've been working with and done specialised sort of leave for them to enable them to come back to work or to remain off.
Okay, thanks for that. And this next question is possibly linked. So it references the need for counselling support for teams. Can it be made mandatory so that each employee is seen by a counsellor for at least a session? This individual has been happy to say they've used the service and found it really useful, but it took a lot of courage to take that first step.
Thank you to whoever that was that submitted that question. I don't know if a number of people on the WebEx saw that earlier this week we had one of our doctors who was talking about health and wellbeing, Dr. Sarclair, who was on BBC News. The focus on health and wellbeing, on supporting our colleagues, making sure they've got access to physical support, but also psychological support, has been on purpose and has been very much the mission of all of my executive colleagues and non-executive colleagues since the pandemic started. We've also put in place a number of longer-term interventions, such as we've been training people in TRIM methodology, which is for dealing with PTSD or feelings of psychological anxiety in the longer term. We've trained up a number of mental health first aiders so that every team in the trust will have a mental health first aider that they can go and talk to. And we're also training up everybody in what we're calling React Level 1, which is a number of interventions and a training that teaches you how to have a psychologically savvy conversation. We're also undertaking a number of mental health stress risk assessments, so they're available to all colleagues across the organisation. And if you undertake that stress risk assessment, which you can do online and you can do on our intranet, it takes a very short time to do, then you would be channelled into either counselling mindfulness. There's all sorts of wellbeing resources that we've got either that have been made available to us that we have purchased to support our staff, and counselling is absolutely a critical part of that. So I would encourage anybody to get in touch who feels that they need some more psychological support and to speak up about it. And thank you to the colleague who raised that.
Thank you for that. Just as Rafaela goes to sit down, I'm just having a quick look at the questions, and we've got a comment from a member of staff saying they felt very supportive during the pandemic and have really appreciated the additional wellbeing support that was offered and was freely available. So we've got some questions coming in about Midland Met, and we've had one submitted in advance. So I'd like to invite Rachel Barlow, our Director of System Transformation, to join me. So as you can expect, Rachel, we've had a few questions that have come in about whether COVID has caused any delays to Midland Met. So I wonder if you could comment on that for us.
I'm delighted at this stage to confirm we haven't experienced any significant delay. So we remain due to open Midland Met University Hospital in 2022. Balfour Beatty, our contractors, have worked in real partnership and quite testing time. It's been the start of a contract, but we've worked really hard with them to make sure that we've kept the building programme on track. We have got 8 days slippage at the moment on a very particular installation, which we hope that will recover by November. So we don't see any significant delay on that basis. Just to reassure you, over the period of the pandemic, the workforce on site, both technical and engineering trade staff, have more than doubled, and we remain on track for that to increase. We've had to invest in welfare facilities so that the staff on site can practice social distancing, and we've had a joint real sort of significant safety focus, as you'd expect a hospital and construction firm to have. So things are looking really positive.
Okay.
We obviously need to consider just going forward with the supply chain and any second pandemic waves, but again, we risk assess that. I also did see a question someone asked about lessons learned, which is a really interesting one. Thank you. We're still learning during the pandemic in this phase, but we took an early view of learning where we've run the scenario we experienced in terms of the admission rates, the oxygen demand on our acute hospitals, through hypothetically the building structure and technical structure and design of Midland Met, and that looks very favourable. We didn't see any risk there. Clearly Midland Met's got a huge amount of side rooms. We'll have the largest negative pressure. There's special rooms that helps contain infections like COVID. We'll have the highest number of rooms per bed base in the country when we open. So the estate itself would really enable us to deal differently with COVID. But that test, in terms of initial lessons learned, looks really positive. It's given us an opportunity just to think about flow. If you have had to come into the hospital, you know that we had to not just COVID and non-COVID wards, we also had lifts and pathways through the hospital like that. And again, we've got the foresight now to design that. So at the press of a button, we could change the way we use Midland Met going forward in the lift and corridors. So yeah, it's really helpful.
Okay, thanks for that, Rachel. I'll go back to a couple more questions we've had submitted in advance. So I'll read them out, and Helen Cope, our Associate Chief Nurse, is going to come and reply to these two. So the questions are: what's happening with the Transforming Care programme, and has COVID-19 stopped the progression of the programme? And are parents and carers still being allowed to do clinical treatment reviews? And if so, how do I go about putting myself forward?
Thank you. The Transforming Care programme, Brad and we talked about the same thing, is led by my colleagues over in the Black Country Partnership. Now, I've been in contact with them, and they have reassured us that the care programme has been classed as what's known as business critical throughout COVID, so that programme of work has continued throughout the pandemic. There's been no slippage in any of their work, and their milestones have all been achieved. What they have been able to relay back to us is that since the programme started, there were 116 patients that were on the programme, and now they're down to 65, which is really good news for them, and it's been a pleasure to work alongside them on that programme. In answer to the second question about being a clinical review, the Black Country Partnership are always having experts by experience on those reviews, and they're more than happy for you, in answer to your question, how do you be one? I've got an email contact address that we'll put through to you outside of here, and then the lady Wendy is more than happy for you to contact her to support that.
Okay, great. Thanks very much for that. So the questions are still coming through. Thank you for sending them in. I've got a financial question that I'm going to put to Diana, which is a really good question. Haven't we shot ourselves in the foot by balancing the books with a 46k profit, as the government said at the beginning they were writing off all the acute trust debts? Dinah, would you like to?
Thank you, Ruth. Thank you. Really great question. And you're right, Trust did have their debt written off, but the answer to your question is no, we didn't shoot ourselves in the foot by delivering a surplus. Without getting too technical about it, we didn't have any debt that was written off under this policy. The debt written off was where trusts have had to borrow cash to pay their staff and suppliers and borrow cash to invest in their estate. And this trust didn't have any debt like that needed to be written off. We have a long-standing financial strategy linked to the Midland Met long-term financial model, which is to deliver cashback surpluses and invest in our buildings and our services and improvements for the benefits of our patients and the local community. And 1920 represents another year where we've achieved that strategy. So thank you for the question.
Great. Thanks very much for that. So we had a question that's been sent through about the R number. And do we have the R number for our Sandwell and West Birmingham population? So I know that we don't have one that covers that area specifically. I think the R number is something that's on a region-wide basis. Just a comment that we do work very closely with Public Health England and Directors of Public Health at our partner local authorities. Our team is partly responsible for the community outbreak support, so we will have a really good idea of any potential outbreaks that should appear in our communities and be able to swab people quickly and advise them on self-isolation in the best way to limit that spread. So thanks for that question. A couple of questions I wanted to pick up that have come in about community engagement. So one comment and a question. The comment is, for many years, the interaction with the community and the hospital link has not been strong enough. Can we start to get this link stronger by engaging with the community more? And how is the Trust moving to do this? And another question that many small local businesses have really stepped up and supported us, as well as local charities. Are we planning a long-term recognition of this support? And are there plans to build on those links we've developed? So I think two really good questions and comments along with a similar theme. So community engagement is obviously something that as a trust we want to develop those links really closely with our communities. And I think we recognise we've got good links in parts, but there are clearly gaps where we need to do more. So we really welcome support from our colleagues and partners in how we best do that. So thanks for that comment. In terms of local businesses and charities, as you say, we've been overwhelmed by the support from business and from charities through donations. It's been a phenomenal outpouring really of support for our staff and the work that they do. We definitely want to recognise their support. Earlier in the year, we did our own clap for business, where we have put the logos of all the businesses on big billboards at City Hospital, and we all stood out and applauded them for the support they've given us. This weekend it's the NHS 72nd birthday, and we want to mark Sunday as our opportunity to thank our communities, and we're encouraging all our staff and partners to put a light in their windows to recognise the contribution that they've made. So just as people have stood with us through the pandemic, we're very committed to wanting to stand with communities in the weeks, months and years ahead. So thank you for those questions. I think that might be the end of the questions that we've had. Let me just have a quick look. Okay, another one's come in. The pandemic has led to innovation. How are we ensuring that we don't go backwards as the situation eases? That's a good question, I think. Liam, would you like to answer that one?
Yeah, I think it's a really good point, and there's a lot of learning that's gone on during the pandemic. We've had to adapt and change the way that we've delivered care. So we've got a restoration and recovery work program that we're working through, and that looks at how can we change care to deliver it, through something which wasn't good for the community, for the trust, and how do we turn that into a real positive and change the way we work. So there's a lot of things around technology and virtual interactions that we're moving forward. There's a lot of ways in service movements and pathways that we're changing, and that's all part of our recovery program. So yeah, we're using that innovation that we learned to make sure that we keep in place what worked well and sort of start afresh from areas that needed a bit of a rework.
Thank you. Thanks for that, Liam. We've got one more that's come through about a planned cycle route to City Hospital. I know Wasim, one of our non-exec directors, will be very pleased to see this question, but it's a comment that there's a planned cycle route to City Hospital. Has the trust pointed out that a route to Midland Met would be better? So clearly that is something that we're working on, and a route to Midland Met is definitely something that's in our plans when we look at the routes through to the new hospital, both walking, cycling and public transport as well. So thank you for that. A question from George about the R rate. George, sorry you couldn't hear that. Happy to reply to you personally about that. So the R rate is something that is available at a region-wide level, not something that's available at a Sandwell and West Birmingham level that we have, but we do support local public health colleagues with outbreak management with a team that does that swabbing. Okay, so I think that's come to the end of our questions that we've had sent in. Thanks very much for everyone who sent in a question and submitted one. Of course, we are able at any time to answer questions, so do send them through to swbh.comms@nhs.net. I'll just now hand back to.
Well done, Ruth. That was very effective. And thank you very much for the wide range of questions, not just the one before, but that was a really good range of questions. And thanks to colleagues for answering that. Clearly, we have our board meetings in public every month. If there, as Ruth said, if there are things that you feel we haven't addressed in sufficient detail, then please let us know. But as I say, our meetings are in public and the details are available on the Trust website. So I encourage you, you want to listen into those, and obviously we've got the technology available to do that. It's now my pleasure to pass on to the second presentation and to introduce James and Simon. I think that this just goes to the core of our drive for integrated care, and without being too trite, the reality is we are completely dependent as an acute and community trust on primary care, and I think you can well argue that primary care for some time has been the most stressed bit of the NHS in terms of the ability to recruit into that sector and the pressure on them in terms of, now clearly you're going to hear about how that's changed on it, but we've always been very keen in terms of the close tie-up with primary care, and having YHP as a partnership team join us, I hope that this presentation is demonstrating how much value that adds in becoming not just a treatment service, but a public health service. That's our plan. So over to James and Simon.
Okay, thank you very much, Chairman. My name is Simon Mitchell. I'm one of the GPs at Your Health Partnership. It's very good to be here today. Obviously, it's slightly strange talking to screens, but as you probably realise, this is the new working world, particularly for GPs. It's something we've become very familiar with. I feel slightly nervous that the exec team are all looking at my back. I hope my bum doesn't look too big in these trousers. We want to talk to you today about Your Health Partnership, our journey to become a big GP organisation, and then on to vertical integration. And then my colleague James here will be talking about how we intend to deliver new services and what we've done around COVID as well. So just go back to the previous one if you could. So Your Health Partnership, in 2011, the GP partners at Regis Medical Centre realised that in order for general practice to both survive the mounting pressures in the NHS and indeed to thrive, that we needed to grow the organisation, and therefore we started to look for other willing, like-minded GP partnerships. The partners at Carter's Green Surgery were of a similar mindset, and in 2012, the two partnerships merged to form Your Health Partnership. We have a shared vision and, importantly, a shared triple aim, which was to make general practice sustainable, to protect high-quality general practice, and to be an employer of choice. Further mergers occurred, with Oakham Surgery in Tividale and then Whiteheath Medical Centre. And so YHP arrived in 2016 as a super partnership, serving 46,000 patients and working from 6 sites. The partners working in those sites had over 200 years of service to the people of Sandwell and were committed to doing everything we could, not just to delivering good services, but to addressing the wider determinants of health. Over the next 2 years, YHP adopted a single GP contract. We developed a shared single back office team, and we brought in specialist staff such as HR and finance teams, and we developed shared clinical teams such as our home visiting service. We also started working as a primary care home, a national initiative that based itself on delivering care and supporting patients in its broadest sense, not just the traditional medical sense. As an organisation, we were delivering a broad range of medical services as well. We had an outpatient contract with the CCG, delivering outpatients in our surgeries. We were providing inpatient medical care at Rowley Hospital and Leasos, and also to the council enhanced assessment beds. And in 2018, we started working with the Trust on the procurement and then delivery of the APMS primary care services at Great Bridge and at Linden. We have a strong history of providing medical education, which chimes with the Trust. We train GPs, we train physician associates, we train medical students, and more recently, paramedics. We pride ourselves on our engagement with our patients, and we're widely recognised as having one of the best developed patient participation groups in the CCG area. Having reached the stage we had, we realised that in order to develop our services further for our population, we needed to become part of something even bigger. Having worked alongside Sandwell on a number of ventures, it felt like a natural fit, and hence we approached Toby Lewis about the possibility of a vertical integration. This was warmly received, and having done all the necessary regulatory work and legal work, we merged YHP formally into the Trust from the 1st of April. We share the same population and we have the same interests. And now, as part of SWBT, YHP patients receive their primary, community and secondary care services from one team. There are no artificial boundaries between providers or awkward conversations about funding streams. We've got the space and the willingness to develop integrated services that make sense to our patients while also supporting the shift in care for the Midland Metropolitan University Hospital. We've been engaged for years on the necessary clinical changes for that hospital move. I can remember sitting down the first time it was presented to us back in 2003, working on towards 2010. And here we are in 2020 and we're still not quite there. But we're already delivering plans around how services will look different. And we've got the ability to deliver those as one single team. And James will talk more about those in a moment. Our staff now, of course, have the support and benefits of being part of the Trust, and they're able to access staff benefits that traditional general practice staff can't. We also want to give them the chance to develop their careers. Traditional careers in general practice are very flat. Now they've got the opportunity to develop and be supported as they also reach for higher achievement. This month, we've managed to complete a recruitment period for GPs. I'm sure you're all aware how difficult it can be to recruit salaried GPs, but we've actually managed to nail 7 of them. And that's because we've been able to offer them innovative roles based in general practice and to develop specialties working alongside Trust colleagues. Again, really vitally important that we can deliver the change for Midland Met. James.
Okay, well, thank you, Simon, and thank you to the board for inviting us to speak today. David has already spoken quite a lot about the Trust's response to the COVID pandemic, and certainly the pandemic has presented our PCN with a number of challenges as well. But I'd like to start by saying just how impressed I've been with the response from our patients, during this period, their level of acceptance of the way things have had to change quite quickly, the goodwill they've shown us, the adaptability, and actually the care they've expressed for the well-being of a lot of our team that we've heard from individual interactions with them. I've been impressed with the response from colleagues during the pandemic as well, again for their resilience and adaptability. The leadership of the CCG have been particularly supportive in bringing the PCNs together to get us to work as one system to respond to this pandemic together. And very much been impressed as well by the leadership of SWBT that's been very visible through the pandemic and very supportive of us, given that we joined your organisation right in the middle of this. So thank you for that. So just thinking about the challenges that COVID presented to the PCN, the immediate challenges, again, has already been mentioned today, and that's the individual risk to colleagues based on their age, their pre-existing medical conditions, and then as the pandemic developed, it became apparent that people from different ethnicities were at different levels of risk. NHS England asked us to develop a system of total triage, which effectively meant shutting the door to patients, something very alien to GPs to do. But something we've had to do, and so we're now in a position where we have to speak to all of our patients before they're able to come in and see us and manage as many of the things, medical problems as we can remotely, which we've done to an extent before, but the degree to which it's happening now has been very alien. Right at the start of the pandemic, we had a 25% absence rate in our workforce, which created a lot of challenges for us. It also became apparent that one of the segments of our population that were most at risk from COVID was people living in care homes. And so we had to move quickly to address that. And as has already been mentioned as well, a lot of people at very high risk of COVID complications were asked to shield in their own homes, and we needed to develop a response to that. But we've very much taken the approach over the last few years in YHP that we must view challenges as opportunities as well to do things differently and to do things better. And I think really there's been a lot of development in technology within the PCN. We're now able to both have telephone consultations, but also video consultations instantly with our patients using a new piece of software. Patients can send photographs of things like rashes or swollen joints, send them immediately to our clinicians to look at, make a decision about what to do next. We've been able to remodel some of the ways that we work. Our catchment area is very big. It covers the whole of Sandwell. And we've managed to really think about how we provide services to patients in the north of our catchment area and in the south of our catchment area. So we had some quite exciting developments around that as well. But also we took the opportunity of a drop-off in demand for primary care services, particularly at the start of the pandemic, to create some space to think about how we respond. And so the things that we actually did was form a COVID leadership group to respond to all the new guidance and challenges we faced. We managed to protect our highest risk colleagues by giving them somewhere to work which was safe, in isolated rooms or at home, away from direct patient contact, but still able to deliver the care that our patients need. We communicated regularly through our social media challenge and SMS campaigns to our patients. Our home visiting team were able to have quite sensitive, advanced care planning and resuscitation conversations with our patients in care homes and with their families. And that was something we thought was very important to get done early on. We developed a mobile oximetry service, so we were able to send oximeters that measure the blood oxygen level to individual patients' home, which could then be phoned through to clinicians at the practice and help them decide whether they needed a hospital admission. And we were able to provide really an enhanced level of care to our patients who were shielding as well, give them direct access to our home visiting team and unlimited appointments through the pandemic, as well as having regular calls from our healthcare assistants and social prescribing link worker to check on their well-being. So I'm proud to have worked with such a great team through this. I think it bodes very well for our future as an integrated organisation. So I'd like to talk a bit now about our future plans, and if you could go forward 2 slides, that'd be great. Okay, thank you. So what we've got on the screen there is a representation of 2 things. The picture on the left is really the traditional model of general practice, where people with a range of problems, be they social care problems, acute medical or long-term medical problems, maternity care, mental health problems, and actually an awful lot of problems that aren't directly related to healthcare, traditionally bring them to the GP. Everyone's registered with a GP. We had a very doctor-led service, and that way for decades we've managed to deal with 90% of contacts in the NHS. But it became quite apparent over the last few years, but that model that was developed in 1948 and before really wasn't fit for the kind of society that we live in now. It doesn't seem right that we have the same access arrangement for a newborn baby as we would for an elderly person who has really complex medical problems. So we really went about, as Simon mentioned, looking at how we could change things, and we became part of the primary care home movement. And I think the model on the right describes really well what we're aiming to do as a PCN as part of SWBT. So we want to develop a truly integrated need, a truly integrated team that meets the diverse needs of our patients as one team rather than as an individual doctor, which is what's happened before. So we're really working hard to develop this shared team that includes GPs, but also physician associates, nurses, healthcare assistants, social prescribing link workers, colleagues who work in the third sector, specialist medical colleagues, and so on. You get the idea. So that as a team, we can tailor our response to each individual's needs. So it's really important to remember as well that the provision of healthcare, there's lots of estimates that it only contributes 10% to people's health and well-being. So it's really important that within that system, we have colleagues from the third sector that can really help us, start to look at some of the wider determinants of health that are contributing to people's well-being. So what are we actually doing? So we some time ago developed a dedicated home visiting team to look after our patients who are housebound or who live in care. And we've really expanded that team and are starting to integrate them with SWBT's community services team, because the district nurses and community therapists are going into the same home of the same patients. And we're looking at joined up ways to do that. And we've made a lot of progress on that. We've got a social prescribing link worker that I mentioned a minute ago who works in our home visiting team and is really helping us to tailor what we do to the individual situation of each patient. We've got a long-term conditions team, which is led by our nurses and now supported by a GP. And very soon we'll have a pharmacist working in that team every day to give our patients the best possible long-term care and medicines management. We're expanding our pharmacy team that we already have to create an even better medicines management team and build on all the good work that we've done over the years on medicines safety and quality. We want to really keep that concept of working in a north and south hub that I mentioned a minute ago after the pandemic, and have some urgent and acute care centres, 2 urgent and acute care centres sitting within our PCN boundaries to meet the needs of our patients much more appropriately, and to free up time for our other clinicians to focus on providing that long-term continuity of care that we know people value but can get undermined by the day-to-day acute demands. We're due to welcome 2 first contact physiotherapists into the PCN who are already working within SWBT on Monday and are looking at completely redefining our pathway for patients with musculoskeletal problems. Likewise, one of my colleagues is doing a lot of work on our plan for looking after children. Our PCN has a disproportionately high number of children and young people, and I think it's up to us to give them the best possible care and support we can for their start in life. We also recognise the disproportionate effect that COVID has had on some segments of our population, particularly patients from BAME backgrounds. So we're taking some time to talk to our colleagues in the third sector and our patients to understand how we can better meet their needs. And actually, this concept of personalised care needs to run through everything we do as one system, both in the PCN, but also I think in the trust more widely. Personalised care has got 3 aspects: advanced care planning, so that people have care that they want and need that's tailored to their personal situations; supported self-management, so that we can support people living at home to look after themselves as best as they possibly can; and also shared decision-making, so that we really get better as clinicians with sharing individual clinical decisions that we made based on the risks that they entail with each interaction. And we've already set up a small working group with some people from the community services, a couple of hospital consultants, and some people from primary care to look at how we can take that forward, and very much want to involve our PPG in that as well. So I think as a PCN, that I could sum that up by saying we need to aim to deliver the care and support that our population wants and needs. We've got to get away from what we've done in the past, which is designing services around what we think is best for people, and design our service around really what our people need. Thank you.
Thanks, James. Just before we finish, we just wanted to just talk a little bit more broadly about GP land that isn't YHP, because although we've been able to address a number of the challenges from the COVID pandemic because we're integrated and quite agile, our colleagues have also shown more broadly how well primary care can respond in a crisis. I think we've seen people working much more closely within their primary care networks, and we've seen the primary care networks themselves working more closely, and rapid progress has been made. And I think that stands us in really good stead for the alliance working that we all need to embrace over the coming year. We know that lots of new leaders have emerged in primary care with new thinking and new ideas, and it's a really exciting time across primary care in Sandwell and West Birmingham. So we're looking forward to working with those colleagues and the Trust as part of the place-based groups as well. That's all we've got to say, Jim.
Thank you very much. Right, James, Simon, thank you very much. I hope you get the sense of energy and drive and innovation and a sort of shared ambition for integrated care, from that presentation. I think that was really powerful, and I hope that shows why we think there's the collaboration, it's only just started in terms of value it can add to our community. Finally, I really want to say a set of thanks. Thank you very much for participating in a highly unusual AGM. We hope next time we'll all be in one room with a following wind. But thank you very much for your, did I see 66? 80. So, I think it's been, clearly an experiment. I want to pay tribute to the comms team who put this together and had to do all the social. So thanks very much to them. As I say, thank you all for participating, and the questions are really valuable. I do need to pay tribute to my colleagues on the board, particularly my non-exec colleagues who tend to have a quiet role in an AGM. A lot of the questions don't go in their direction, but I want to thank them personally for the support they've given the board, the leadership of the committees, and all the work they do outside the committee and board space, and the support they've given me personally. They share our passion for integrated care and for our ambitions as we move towards the new hospital. Can I also thank our partners in the community, and I hope what's come clear from today that we're completely interdependent with partners in the community, and I think that the sense that place is, the sense of place and understanding, if we're going to understand public health and change the way services shape up that, then I think working at a place-based level, I hope has come through today, because we see that as a critical driver, and I think that the pandemic has just accentuated the power of that. I think that's our view. So thanks to our partners who have worked innovatively through the year. I hope it comes across that we're really grateful for the way that they've responded, not just in the pandemic, but in the way we're with them trying to transform services focused on the patient and very much on public health outcomes and health inequalities. Finally, can I pay tribute to our exec team who have worked incredibly hard through a very tough period on your behalf. So thank them for the support and the leadership they've shown through their team. So, and thank you very much. And we really appreciate your participation. Thank you.